moving to our next topic, we will be talking about further honing the immune system, and we will be talking about cellular therapy for the treatment of blood-related cancer. We have a distinguished professor, Dr. Mohammed Karfan Dabaha, who's the chair of bone marrow transplant, who will start CAR T-cell therapy at Mayo Clinic. And he's a passionate researcher, clinician, the same as Dr. Knudsen, and he will show us how CAR T-cell can change the therapy of blood-related cancer. We're beginning to see leukemias that were incurable before now can have 1, 2, 3, and hopefully longer length of life, what we call fatal leukemias, terminal leukemia. Here is Dr. Karfan. Please welcome Dr. Karfan.
Good morning, everybody. First, I would like to thank all of you for being here this beautiful Saturday morning. And I also would like to echo the words of Dr. Tan that really we are here for you, and you are the most important persons in this meeting. And we would like to share with you all the innovation that we're bringing to our program at Mayo Clinic. So our mission at Mayo is really to inspire hope and to contribute to health and the well-being by providing the best care to every patient through integrated clinical practice, education, and also research. The vision of Mayo Clinic, and going back to our founders, is that we shall always provide an unparalleled experience as your most trusted partner for healthcare. And I have joined Mayo over 2 months ago, and I can tell you that this value lives every single day at the institution. The needs of the patients always come first, and that's really what motivates us to provide the best therapies available. I have divided my presentation into 2 parts. First, what we call hematopoietic cell transplantation, or traditionally bone marrow transplantation. And this is a type of therapy that a little bit different from Dr. Knudsen's talk, in that it is certainly non-specific. We use the immune system of a healthy donor in the case of allogeneic transplant, or in the case of autologous, we try to explore to the most the ability of chemotherapy to eradicate cancer, and then try to rescue the human body with stem cells that we have collected before. So I'm going to be discussing the indications of transplantation and how the field has evolved over years. There are indications for autologous transplantation, diseases like multiple myeloma, Hodgkin's lymphomas, and certainly some solid tumors like testicular cancer can be cured with autologous transplantation. For allogeneic transplantation, traditionally we relied more on what we call related or family transplants. And certainly with better understanding of the HLA human leukocyte antigen and how to overcome the barriers of rejection, we really moved into an era of unrelated donor transplantation, where patients who are not lucky to have a donor from a family, in this case typically siblings, we should be able to perform the procedure if we were to find a donor that is not family related. More recently, based on work by our colleagues at Johns Hopkins in Baltimore, we have really brought this new technology called haploidentical transplantation into the clinical arena. And that means basically that even in those cases where the family does not have a perfect match, we can still perform the transplant. So this has really allowed us to have donors available for over 95% of our patients. And this is why haploidentical is necessary. If this is a chart that shows what is the probability of finding a donor based on the patient's ethnicity or racial background. So for instance, if a patient identifies him or herself as white European, we have over 70% chance of finding a donor in the registry. Whereas if somebody identifies him or herself as African American, the probability is around 18 or 20%. Similarly, for patients of Hispanic, and in this case, South or Central American Hispanics, the probability is no more than 30%. So certainly, this precludes offering a potentially curative treatment to patients who otherwise would not have donors. So haploidentical transplantation, because we can use parents, we can use children, we can use even cousins, have really expanded the pool for these groups where we don't have a high number of donors to actually be able to receive a procedure with the curative intent. At Mayo and certainly other centers in the country, we have moved away from using age as a limiting factor for transplantation. So we don't restrict anymore. And I'm going to be sharing with you some data from the Center for International Blood and Marrow Transplant, which is based in Wisconsin, that really this paradigm has been shifting towards using more of a functional age. So we look at the patient overall function. Somebody who is over 70 years of age and plays golf 2 or 3 times a week and walks a couple of miles a day, that patient is a candidate for transplant, provided that he has or she has good organ function. And this reflects that fact. So here's autologous transplant. These are when we use the patient's own cells to do a transplant. You can see that back in the year 2000, we rarely offered the procedure because we thought that it was too risky to offer. And in 2016, we can see that the number of patients who are receiving autologous transplant above 70 years of age actually is increasing. And if you were to look over the last 8 years, from 2008 to 2016, the fastest growing proportion of patients who are receiving autologous transplant are actually 60 years of age or older. So certainly we have made significant progress. Similarly for allogeneic transplant, again, this is a little bit of a riskier procedure, and because we have to suppress the immune system of the patient to allow the donor cells to come in, so higher risk of infection and higher risk of organ failure. But you can see that we are starting to break that barrier of not restricting the transplant to younger patients and actually to allowing them to patients of more advanced age. So certainly a lot of progress in that area. The number of transplants in the United States continue to increase annually. Autologous transplant in 2016 exceeded 14,000 cases, and for allogeneic transplant, the number exceeded over 8,000 cases. Now, where is that continued growth coming? Obviously, by discovering what I call other relative, or meaning the patients who do not have a full matched sibling, we are actually using parents or children or cousins or even uncles or distant relatives to allow the procedure to be offered to these patients. And you can see that in the orange curve here, the fastest growing over the past few years have been the use of haploidentical transplantation. So I'm going to spend some time about what are the indications for transplantation, and this is a work that was led by the Center for International Blood and Marrow Transplant Research in collaboration with the American Society of Blood and Marrow Transplantation. And here are some of the diseases that I summarize for autologous transplant, generally Hodgkin's lymphoma, when the patients do have a first relapse, non-Hodgkin's lymphomas, various types of it, multiple myeloma, primary amyloidosis, and other what we call plasma cell dyscrasias, and also solid tumors, particularly testicular cancer and what we call germ cell tumors. Recently, we have had interesting data that has been published showing that patients who have benign disorders could benefit from an autologous transplant, and this is what we call systemic sclerosis in the broad category of scleroderma and those diseases. Allogeneic means getting a transplant from a donor, and that's predominantly acute myeloid leukemia, which is the #1 indication nationwide, acute lymphoblastic leukemia, myelodysplastic syndromes, Hodgkin's and non-Hodgkin's lymphomas when they relapse, and also for some benign disorders, there is strong clinical evidence that sickle cell disease actually is benefits from an allogeneic transplant. Here I summarize some of the indications for transplant which were performed in 2016. In green are the autologous transplants, and the large majority were patients with multiple myeloma. Non-Hodgkin's lymphomas is the second more common, Hodgkin's lymphoma, and then some of the solid cancers I summarized earlier, testicular cancer and germ cell tumor. And for allogeneic transplant, acute myeloid leukemia being #1, followed by myelodysplastic syndromes and acute lymphoblastic leukemia. Myelodysplastic syndrome is a disease that typically does occur in patients of more advanced age. Here we're talking 65 or older, and this is a population that we have in the state of Florida in a higher proportion compared to other states in the country. Significant progress, and this is a paper from our colleagues from the Fred Hutchinson Cancer Center in Seattle, where they looked at over thousands of patients, and they look at 2 time points here between 1993 and 1997, where they performed over 1,400 cases, and more recently between 2003 and 2007, and we can see that the risk of dying from a transplant, an allogeneic transplant, has come down from 30% to a little bit under 20% or 17%. Now, the numbers still are high in my opinion, and we need to do much more to bring these numbers to a better probability of surviving the procedure, but this represents around 56% improvement over the last, over a span of 10 years. So certainly more work to do, but things are moving in the right direction. And I think what one of the main reasons we have seen that is because we certainly have better strategies to prevent this phenomenon, what we call graft versus host disease, which is basically the donor cells attacking the patient's human body. And we have seen that over the years, the proportion of bad GVHD, which is grade 4, has been decreasing, like you see here when we look at overall grades, or even in specific organs like this liver or like the gastrointestinal tract. Now, a procedure like an allogeneic transplant is certainly very complex from the logistical standpoint, and going to the point made by Dr. Tan in that it is not possible unless we have caregiver support. And this is where we really need committed caregivers, because we have certainly a high risk of dying the first 100 days from the transplant, but also even beyond the 100 days. So this is a procedure that requires a lot of close follow-up, surveillance, and having a very attentive caregiver. Within the first 100 days, this is when unrelated donors were analyzed by the Center for International Blood and Marrow Transplant Research. There is a risk of the disease coming back always, but there is always organ failure as a main concern, around 15%, and that's something that we need to, we educate caregivers to look for certain signs. For instance, if a patient is having chest pain, to make sure that they notify us and they go to the nearest emergency room, or if the patient have signs of infection. And in many cases, this patient cannot have any fever as a sign of infection because they are not able to mount an immune response because they are still very suppressed from the immunological standpoint. So many times we rely on the caregiver to tell us in the middle of the night, my husband or my wife or my child is not behaving the way he was behaving a few hours ago, and that's an indication that a serious infection may be cooking. So this is important because this is really, in my opinion, what makes a big difference. Allogeneic transplant survival is improving, and this is, I would say, across all over the country. We have better strategies to prevent infections, to treat infections, and also to select our patients better for transplantation. And I think this is the second part of my talk, which is it's really bringing the concept of immunotherapy, which I echoed Dr. Knutson's story where I used to go to those immunology meetings many years ago, and I would sit in a very small room and say, is this going to ever grow and become a reality, or is this just going to be a fantasy? And in reality, it became a reality last year with 2 products approved for treatment. The first one for acute lymphoblastic leukemia in August of 2017, and the second one for the treatment of some types of large cell lymphoma called diffuse large B-cell lymphoma. So CAR T-cell therapy, it really became possible by this technology, what we call adoptive cell transfer. And this is a very rapidly emerging immunotherapy approach, and many more CAR T-cell therapies, in my opinion, will become available in the next few years. So, but the principle here is as Dr. Knutson showed up on his presentation, is to try to collect and use the patient's own immune cells to treat their own cancer. How do we redirect the human cells or those lymphocytes to actually see the cancer? They go through a process when cancer happens, somehow this immune system is fooled by the cancer. And the idea here is how do we get those cells and we retrain them to look at the cancer and find it. There are different types of adoptive cell transfer. I'm going to just name here, but one is called tumor infiltrating lymphocytes, and this is being explored in many solid tumors as well as in some blood cancers like multiple myeloma. And then I think the one that has made the biggest impact is chimeric antigen receptor therapy, or CAR T-cell. And this is the one that has, in my opinion, advanced furthest the field and has moved into from the concept of development to the concept of clinical practice, where we have now 2 products that are FDA approved for treatment of one, acute lymphoblastic leukemia. The approval of the FDA limits the use of CAR T-cell for ALL up to age of 25. There are other studies that haven't matured yet, where we are looking at ALL in adult patients. And for large cell lymphoma, there are restrictions of patients having to have failed at least 2 prior lines of therapy and have measurable disease. So I'm going to try to summarize here a very complex procedure, but what we, for CAR T-cell, what is done is basically the patient's cells are collected through this machine called an apheresis machine, and those cells are shipped to the manufacturer, who for ALL is Novartis, and for diffuse large B-cell lymphoma is a company named Kite. And what they do is basically they process the cells. We have this process called transduction, where we use a virus to insert an antigen there. And then those cells have to meet a certain quality standards before they can send back. In the meantime, the company will notify the center that you are expecting, you should be expecting your cells within this particular time. Few days earlier, the patient will get what we call lymphocyte depleting chemotherapy, typically for 3 or 4 days. And then we will infuse the cells, the CAR T cells. So this technology, although it sounds new, it has gone through different evolution phases, where we have moved from 1st generation CAR T cells to 2nd, and now more recently 3rd generation CAR T cells. And now we have even multi-target for CAR T cells, where we can actually target more than one antigen. What we have so far is for what a disease, the type of lymphoid malignancy is called B cells, and the one that is commercially available is a CD19, which is a marker that typically we find in lymphomas and ALL. So certainly the life expectancy and survival has dramatically improved when we look at the data for acute lymphoblastic leukemia. Again, these were some of the studies that have been in development, whether in New York or Pennsylvania or in Washington, in Bethesda, or in Seattle, where we were seeing responses that these are patients that were considered hopeless cases, where now the disease is responding in over 70% of the cases, and in some up to 91% of the cases. And this is the study that led to the approval of the first CAR T-cell in the United States. And I believe these products have have not yet been approved in Europe or South America, to my knowledge. And this study enrolled patients, young patients, median age was around 11, and some were adolescents and young adults up to 23 years of age, where these patients have failed at least 3 lines of therapy on the median, or the number of therapies were around 3. In some cases, some patients have failed up to 8 lines of treatment. And these patients had around 74% on median number of blasts, which means that this disease is very aggressive and the bone marrow is filled up with this blast. And 61% have already failed an allogeneic transplant. So if you were to just look at this line, the life expectancy of somebody who would fail an allogeneic transplant and being alive a year later is less than 10%. So that, just want to keep that as a benchmark to show why this study is important. So 75 patients were treated with this product called Kimbria, and they were evaluated for efficacy. So by 3 months, 81% of these patients did respond. And all patients who respond, to the best of our knowledge, using this technology called minimal residual disease assessment, where we look deep into finding cells, sometimes 1 in 10,000 or 1 in 100,000, we could not find the disease here. And by 1 year, 76% of these patients were alive. So if you compare that with less than 10%, you can imagine the importance of this, of having this therapy available for these patients. And here, at the time the investigators followed up this patient, the median duration of remission was not reached, meaning that these patients were continuing to have their disease holding, their remissions holding up, meaning that they were technically cured, although I would like to see longer follow-up to hopefully see that these numbers are held. But so far, this is extremely encouraging. The procedure is, as such, cannot be offered in a clinic or in an office-based practice, so it has to be in a hospital that can offer bone marrow transplantation, and that can have a very complex setup, so because patients can get sick. And this is what we call the overall safety profile, where almost all patients at any time did develop some side effects. So when you look at within 8 weeks of infusion, around 99% of these patients, 74 of the 75, did have some sort of adverse event, and the majority were attributed to the drug or to the CAR T cell. And those could persist for later on, although the incidence of side effects after 8 weeks tend to be generally lower than before. So why is this a treatment that is not every center can offer? Is because of what we call cytokine release syndrome. This is certainly when you try to activate the human body and you infuse these enormous numbers of cells, the human body tends to react to it also, and you can have, could be grade 1, as simple as fevers, but sometimes this patient would require more aggressive intervention. In fact, around less than half of these patients, 47%, did require some stay in the intensive care unit, and they had to receive oxygen in a third of the cases. So the good news is that we do have treatments to counter these side effects, and we have actually, they have made the procedure much safer to administer. So for diffuse large B-cell lymphoma, the story is similar. This is the product that was approved in October of 2017. It's called Yescarta. This product is manufactured by a company called Kite, which now had been acquired by Gilead Pharmaceuticals. And to give you again some background, patients with large cell lymphoma who do relapse or are refractory to at least 2 lines of treatment, one would anticipate that only 20% would be alive 2 years later. So the other side of this number is that 80% will be dead 2 years later. And with CAR T cells for lymphomas, after 18 months, we have been able to improve this number from 20% up to 52%. So more work to do, I don't think that this story ends here. There are certainly new generations of CAR T cell that will evolve, hopefully make these CARs smarter and more effective. And lastly, there were some data shared last week at the transplant meeting in Salt Lake City, where these numbers at 2 years were continuing to hold up. So certainly very promising as a possibility for curing this patient, but we need to see more data following up. So again, drawback similar to the previous product for lymphoblastic leukemia. It's highly toxic. Similarly, 90% of patients could develop any type of toxicity, and some of them would develop neurological events, which could be confusion and up to sometimes having seizures. Deaths that were reported due to treatment were 3%. So again, ideally, we should have it 0%, but in the big scale, considering how complex this is, we consider that this procedure is relatively safe. So our program at Mayo Clinic, we do perform autologous transplant. We have excellent, world-renowned experts in the field. Some of them you will be meeting today. In this meeting, my colleague, Dr. Taimur Sherv, expert in lymphomas and also amyloidosis, Dr. Sekandar Ailawadi in multiple myeloma. And we do also offer allogeneic transplants. We offer, whether sibling or unrelated, we do perform mismatched transplants at Mayo. We have the technology for haploidentical donor transplantation, and we also offer cord blood transplantation. We anticipate that by May of this year, we will be starting to offer CAR T cell therapy. We are going through the process of accreditation as required by the FDA, and we should have the product for large cell lymphoma in May, and hopefully for acute lymphoblastic leukemia sometime in June, end of May or June timeframe. We are also working on bringing clinical trials for other diseases, some of them in solid tumors, to make sure that we have everything that we could offer to our patients, because as I mentioned earlier, in our values, the need of the patient always comes first. And with that, I would like to thank you for your attention